kind of tell the difference between the anterior and posterior fontanelle, then that'll kind of point you in the right direction of where it's going. And then in relation to the mother's pelvis, that's how you figure all that out. All right, so let's recap what we've done so far. We've checked the patient's records, we've looked at the dates and the ultrasounds, we've looked at all the screening labs, we've started our physical exam, we've done vital signs, we've looked for hypertension, we've done an abdominal exam, we've checked fetal heart tones, we've done a pelvic exam, we've checked the membranes. Are they ruptured? Are they not ruptured? We've done a Fern test, we've done a nitrazine test, maybe they're positive, maybe they're negative. We've remembered the 5 components of the digital exam, the Bishop score. So dilation, that's between 1 and 10 centimeters. Effacement, percentage, 0 to 100%. Station, it's going to range from either -3 to +3 or -5 to +5. Cervical consistency, is it firm, is it soft? We've done cervical position, is it anterior, is it mid, is it posterior? Hopefully we've had a good feel of the baby's fontanelles and we can tell the position of the baby's head. So with just that bit, and it actually doesn't take that long. I mean, you can do this in 5 minutes. You can check this person, especially if there's any question of what's going on. You can get a lot of information very, very quickly about the status of someone's labor just with these few things. Now, obviously, you have to repeat a lot of this and you don't want to miss things, but if someone's coming in and you're like, I need to know if this person is about to deliver a baby or not, you can find out relatively quickly.
Hi, I'm Dr. Mike McInnes, and I'm here to go through the answers to the quick review in your study guide. Let's get started. First question, a 25-year-old pregnant female at 39 weeks gestational age presents to labor and delivery. She believes that her water has broken. On pelvic exam, she has some fluid in the vagina. The nitrazine paper turns immediately blue. Why does this happen? So normal vaginal secretions are acidic, but amniotic fluid is alkaline, which is why the nitrazine paper turns blue. It's testing for alkaline substances. Next, compare and contrast the anterior and posterior fetal fontanelles. So the anterior fontanelle is larger and it's more diamond shaped, and the posterior fontanelle is smaller and it's shaped like a triangle. Next, while examining a laboring patient, you estimate that the fetal head is at the level of the maternal ischial spines. What is the station? This is 0 station. Remember that before the fetal head reaches the ischial spines, the numbering is negative, and then once it's past the ischial spines, it switches to positive. At the introitus, the station is either +3 or +5, depending on which scale you use. Next question. A 24-year-old pregnant patient presents to labor and delivery with regular contractions every 5 minutes. After a pelvic exam, you calculate her Bishop score at 9. Is this patient likely to continue to spontaneous vaginal delivery? Well, yes. A Bishop score of 8 or greater has a high likelihood of progressing to spontaneous delivery. So that's the end of the quick review. Let's go back to Dr. Lewis.
Next, we're talking about monitoring of the fetus in labor. So this is an important subject we need to talk about. The first step in maintaining the health of the baby is maintaining the health of the mother. So luckily, it's not very difficult to evaluate the health of the mother with vital signs and physical exams. Now, we have a much more difficult task when we need to evaluate the health of a baby. It's hard to get in there and check that baby's pulse and pump up a baby blood pressure while they're still in the uterus. So what do we need to do? Well, we often will monitor the heart rate of the baby by continuous electronic fetal monitoring. Now, the rationale for this is that the fetal heart rate patterns are an indirect marker of the fetal cardiac and medullary responses to blood volume changes, acidemia, and hypoxemia. Now, this position is largely based on the experience of experts and medical legal precedent. Right now, there are no trials that have proven that electronic fetal monitoring reduces mortality. It doesn't reduce the rate of cerebral palsy, stillbirth, low APGAR scores, neonatal intensive care unit admissions, or neurological injury. So even though we get a lot of information, though we think this is helpful stuff, hasn't really been shown to have a lot of benefit overall. Now, there's going to be lots of debates about this. Send your hate mail to me if you want. But truth be told, we're not really going strictly by data here that makes us want to do this continuous electronic fetal monitoring. Now, it does, unfortunately, however, lead to higher operative delivery rates, so more C-sections. So this is a very controversial topic. The United States Preventative Service Task Force, and we use this a lot for whether or not we need to do screening for certain things. And the Canadian Task Force on Preventative Healthcare have said that the routine electronic fetal heart rate monitoring for low-risk women in labor is not recommended. So they've even said that there's not enough statistical evidence that sticking a continuous monitor on a low-risk woman really has any benefit. Now, ACOG, or the American College of Obstetrics and Gynecology, say that high-risk pregnancies should be monitored continuously during labor, and then either electronic FHR, which is fetal heart rate monitoring, or intermittent auscultation is acceptable in uncomplicated patients or low-risk patients. So statistically, we haven't really seen that the low-risk woman needs constant monitoring, but ACOG says it's okay if you do it. Therefore, you will have patients who do not want to have a monitor strapped to them. And the data probably supports this opinion. However, there's some other confounding problems here. This might go against a lot of hospital policy and protocols. So why do we have these protocols in place here? Well, it's not an easy question to answer, but a big part of it is lawsuits. So there's a lot of medical legal precedent for the use of fetal heart rate monitoring during labor. So hospitals and physicians try to protect themselves by doing the continuous monitoring, though there's still not great data that this is really doing us much good. So let's talk about how we interpret all this stuff. So a normal fetal heart rate is between 110 and 160. Now, a consistently elevated heart rate may indicate infection or anemia or hypoxia. Any persisting bradycardia over 2 minutes is considered quite worrisome, and immediate action may need to be taken. So bradycardia is not so good. So when you go to labor and delivery, most of the moms there will have straps around their bellies, which will have this continuously measuring of the fetal heart rate. And they'll have this tracing. You'll see it over there. Sometimes it's electronic. A lot of times they still have the paper version of it, and you'll sort of see this undulating pattern of the fetal heart rate. We gain some important information from another thing, the external tachometer. So the tachometer is also placed on the belly. It's on the fundus of the uterus, and it measures and records contractions. So the external tachometer is useful in measuring the frequency of contractions, though it's not very accurate in measuring the strength of contractions, though you can sort of see the relative differences between each contraction, but you can't really tell from patient A to patient B which one of these two is having a stronger contraction from this external tachometer. So what do fetal heart tracings and contraction patterns tell us about the health of the baby? Well, first, we get a baseline fetal heart rate. And remember, our normal is between 110 and 160. Next, we want to look at the heart rate variation from that baseline. We call this variability. It's absent if you have less than 3 beats variability, minimal if it's between 3 and 5 beats, moderate if it's between 5 and 25 beats of variability, and marked if it's greater than 25 beats. So healthy babies have variability. We like to see nice reactive changes in their baseline heart rate. So in order for a tracing to be considered reactive, and that's an important word, there should be at least 2 accelerations of at least 15 beats per minute over the baseline that last for at least 15 seconds within a 20-minute time period. So you look at these 20-minute sections, and you want to see 2 of these big accelerations that are kind of gradual. They're not just up and down. They're over a nice 15-second, it goes up, it goes down, it goes up, at least 15 beats. So we call that reactive. Also be aware that babies do sleep, and they are inactive, and this can lead to less variability, so you don't want to freak out if you see a non-reactive one right away. You'll see these little buzzer things. We had in our training this little, almost like a game show thing, and you're buzzing the baby's head or the body through the mom's belly. The next section is about deceleration. So we just talked about accelerations. We talked about how we've looked at these and made them reactive. So let's talk about some decelerations, or we also refer to these as decels. Now, here we use the information for the tachometer. So we're looking at the timing of contractions in order to further evaluate the decels on a tracing. So there are 3 types of decels. First are early decelerations, and they begin and end at about the same time as the contraction. So they are the result of increased vagal tone secondary to head compression during the contraction. So contraction starts, immediately you get an early decel, but by the time that contraction releases, you're back to your baseline. Variable decels. Now these can occur at any time, and